Hello, everyone. I'm Dr. Mohammed Tinawi. I'm a nephrologist in Northwest Indiana. This nephrology update pertains to the American Society of Nephrology Kidney Week 2024 in San Diego, California. So let's get started. For this update, I chose 12 studies that were published at the time of presentation. So there was a simultaneous publication because these studies were deemed to be of such significance to warrant simultaneous publication. Moreover, now you can find the reference and the data is complete and it's been peer reviewed. So the first study is microvascular inflammation of kidney allografts and clinical outcomes. So we all know the BAMF classification. So in the most recent update in 2022, there were two new diagnostic entities for antibody-mediated rejection. So the first new type is microvascular inflammation, MVI, without evidence of antibody-mediated response, meaning DSA negative and C4D negative. Now, the second type is probable antibody-mediated rejection. So here we have DSA positive, donor specific antibody positive, but C4D negative. So what did they do in this study? They reviewed 16,000 biopsies from like 30 centers in North America and Europe, and they found that these two novel types exist in 5% of biopsies, and most of these cases were considered non-rejection prior to the new classification. So there was importance in identifying MVI without evidence of antibody-mediated response, meaning the first type I mentioned, DSA negative, C4D negative, compared to non-rejection cases, because the hazard ratio for allograft loss was 2.1, the confidence interval 1.5 to 3.1. Therefore, that was significant. The second type, DSA positive, C4D negative, was not different from non-rejection cases, meaning the allograft loss was not different. Median follow-up was 5 years, and the study confirmed the importance of identifying patients with MVI or microvascular inflammation with DSA negative C4D, DSA negative C4D negative due to increased risk of graft loss. Now, the limitations of this study, we don't know about the medications. They differed between centers. They were not documented. Therefore, we cannot draw conclusions about the relationship between treatment and clinical outcome. Before I go on to the second study, I'd like to mention that I'll provide a link to an article that I published that has more information and has all the references, so you really don't need to take any notes. Second study is long-term effects of empagliflozin, an SGLT2 inhibitor, in patients with chronic kidney disease. Many of us are familiar with the EMPA kidney trial published in 2023 and showed that patients with CKD at risk for disease progression when given empagliflozin, the risk of cardiovascular death and kidney disease progression was lower over a median follow-up of 2 years period. So now what happens if we stop the medication? This is the subject of this trial. So they took about 5,000 patients from the original trial, about 75% of the patients, and they were followed for about 2 years, okay? During the combined periods, which is like 4 years, the results were still significant. So they allowed prescribing of empagliflozin, but empagliflozin prescribing was 40% in the placebo group and in the original group. So there was no difference. Okay, so the risk of the composite of ESRD or death was 16.9% in the empagliflozin group and 19.6% in the placebo group. So hazard ratio was 0.81, so that's significant. Also, for the risk for cardiovascular death, reduction was significant. Hazard ratio was 0.75%. There was no difference with regard to non-cardiovascular death. And when you looked at the composite just for the follow-up period, the results were still statistically significant. So what's the conclusion? The conclusion: in patients with CKD at risk for disease progression, empagliflozin treatment continues to show renal and cardiac benefits up to 1 year post medication discontinuation. The reason, the mechanism for this is unclear. Limitations: patients from Japan were not included. Creatinine measurement was done locally and not centrally, like with many other trials. And we don't have data regarding hospitalization, at least not yet. So first, I'm going to provide the background on trials related to IgA nephropathy because it was a major theme in this meeting. So let's go through this four-hit hypothesis. So hit one, the pair patches in the ileum, in the distal ileum, and the mesentery, they produced IgA1 that is galactose deficient. So now we have a circulating galactose deficient IgA1. Okay, now since this is not something normal to the body, we're going to have autoantibodies against this galactose deficient IgA1. And those antibodies can be IgA or IgG. Okay, now hit 3, we have now the IgA1 that is galactose deficient, and we have the antibodies against it. So what are we going to have? We're going to have circulating immune complexes. So these immune complexes in hit 4, they're going to find their way to the kidneys, and they're going to deposit in the mesangium, in the glomerular mesangium, and they're going to induce complement, and then this is going to cause injury. Injury meaning inflammation, interstitial fibrosis, and renal injury. Now, we also have to pay attention to two factors essential in maintaining this B cell pool. The first one is called BAFF, B-A-F-F, B cell activating factor, and the second one is called aproliferation inducing ligand, or APRIL. Both are produced by the intestinal epithelial cells and dendritic cells. Now, the level of BAFF and APRIL are increased in patients with IgA nephropathy, and higher levels of BAFF is associated with the severity of histologic injury. Now, each medicine that was approved for IgA nephropathy really target a certain mechanism. Okay, the bottom line, they all reduce proteinuria. For most of them, we don't have data on the eGFR trajectory. So currently, if you go to clinicaltrials.gov, there are 32 clinical trials as of October of 2024 investigating treatments for IgA nephropathy. So all of a sudden, we have a proliferation of trials. Well, some are targeting C5 inhibitors, some targeting complements, some targeting endothelial receptor antagonists, some are anti-APRIL, other are anti-lymphocyte stimulator, BLYS, and APRIL inhibitors. So we're having all kind of investigational medications. So I'm going here to go through abstract that were actually published, but there were a lot more abstracts that were not published. So this way you'll get a taste of what's going on in IgA nephropathy. The first study we're going to discuss regarding IgA nephropathy is alternative complement pathway inhibition with iptacopan in IgA nephropathy. Now, iptacopan inhibits the alternative complement pathway by binding to factor B. Now, this medication is now approved actually by the FDA for treatment of IgA nephropathy under the name Fabhalta, and it is made by Novartis. Now, you have to know that there's a black box warning, so the distribution is restricted, and there's a REMS program where you have to register due to risk of serious infection caused by encapsulated bacteria. This is like strep pneumo, Neisseria meningitis, and Haemophilus influenza type B. Now, with that in mind, let's go through the study. 222 patients, all biopsy-proven IgA nephropathy. They were optimized on ACEs or ARBs. Here, like SGLT, they weren't commonplace, so ACEs or ARBs, and they continued, despite that treatment, to have a urine protein creatinine ratio over 1 gram per gram. So at that point, they were either given 200 milligrams of iptacopan or placebo twice daily for 2 years. This is an interim analysis that was done at 9 months and indeed showed reduction in proteinuria by 38% with iptacopan compared to placebo. The medication was well tolerated. Now, the study now will be carried over for 2 years, so we know what's going to happen with EGFR. So we can conclude that iptacopan, which inhibits the complement alternative pathway by binding to factor B, leads to significant reduction in proteinuria in IgA nephropathy. Now, the limitations, obviously, proteinuria is a surrogate, not hard endpoint. We need the 2-year data to know the effect on EGFR trajectory. Another limitation I would put is that this medication is new and is extremely expensive. Next study is the efficacy and safety of ravulizumab in IgA nephropathy. So ravulizumab is a second-generation C5 inhibitor humanized monoclonal antibody. So here we have a phase 2 trial. 43 patients were given the active drug, ravulizumab, intravenously every 8 weeks. 23 patients were given placebo. They were followed for 26 weeks. Patients all were biopsy-proven IgA nephropathy, had eGFR over 30 or equal to 30, proteinuria equal to or over 1 gram. They were all on ACEs or ARBs. Then we have the open label phase when everyone got on ravulizumab weeks 26 to 50. So in short, ravulizumab did reduce proteinuria by about 42%. Placebo was only 17%. When everyone received ravulizumab, the same reduction in proteinuria was achieved. So since this is a small study, phase 2 trial, there is a phase 3 trial that is ongoing. What's the conclusion? Ravulizumab is a C5 inhibitor that leads to significant reduction in proteinuria in patients with IgA nephropathy. The limitations are obvious. This is a phase 2 trial. We have a small number of patients. Next study is the selective endothelin receptor antagonist SC0062 in IgA nephropathy. This is a phase 2 trial, and we have a selective endothelin receptor type A antagonist called SC0062. This is a dose-finding trial, so we had patients with biopsy-proven IgA nephropathy, proteinuria equal or over 1 gram per 24 hours, and they were all on ACEs or ARBs. So we have 34 patients given placebo and 97 patients given the active drugs, different doses. Okay, 5 milligrams, 10 milligrams, 32 milligrams. And the SC0062 was helpful, and the higher the dose, the more the reduction in proteinuria. For example, with 20 milligrams, there was 51.6% reduction. So in this phase 2 trial, this is a novel selective endothelin receptor type A antagonist. It did reduce proteinuria. It did not cause edema. There was not much significant side effects. Of course, this is still a phase 2 trial, a dose finding. So we have a small number of patients. We don't have any information on long-term side effects. We don't have information on the eGFR trajectory. Next study is with atrasentan in patients with IgA nephropathy. So this is another endothelin receptor antagonist type A. So this is a phase 3 trial, so we have more patients, 270 patients, all patients IgA nephropathy biopsy proven, proteinuria more or equal to 1 gram, eGFR over 30. Now, here patients were randomized either to get this atrasentan 0.75 milligram, which is again oral endothelin receptor antagonist type A, or placebo for 132 weeks. And we have here an analysis, interim analysis at 36 weeks, and indeed there was a greater decline in proteinuria between 44 to 26%. Placebo, the decline was only 3%, so on average 40%, kind of the same like we've seen with the other studies I just presented. There was more edema but no heart failure. So this atrasentan, a selective oral endothelin receptor antagonist type A, was significantly reducing proteinuria in patients in IgA nephropathy compared to placebo. Limitations, the study was only for 36 weeks, so we await the results of the full study when it's completed. Most patients were Asian or white, so we cannot generalize it to other ethnic groups or to patients with proteinuria less than 1 gram. The last study related to IgA nephropathy is the long-term results from an open-label extension study of atacicept. So atacicept is a fully humanized fusion protein inhibiting BAFF and APRIL. We talked about those just a few slides ago. So initially we had a 36-week double-blinded study. This is an extension. This is another 60-week open-label extension study. So we have a total of 96 weeks, 113 patients. Now, this study had no placebo arm, so patients were just followed. They were self-injecting this atacicept, 150 milligrams once a week. And the results were really positive. So atacicept resulted in reduction in proteinuria by about 50%. The serum level of galactose deficient IgA1 was reduced, proteinuria was reduced, and eGFR slope remains stable. So this is kind of everything. So now all we need is a bigger study with a larger number of patients. So this BAFF and APRIL inhibitor is useful in patients with IgA nephropathy. Next study is early individualized recommendations for hospitalized patients with acute kidney injury. This study investigated whether in case of in-hospital acute kidney injury, sending electronic health record alerts would help in reducing the need for dialysis or reduce mortality within 14 days. So we have two groups, 4,000 patients, 7 hospitals. And the action was to send electronic health record recommendations, alerts regarding testing, medications, volume status, potassium or acid base within 1 hour of detecting acute kidney injury. Bottom line, there was no difference between the two groups with regard to dialysis or mortality over the following 14 days. So those alerts did not help. The limitations of the study, subjects were not enrolled at all hours or on weekends, and we don't know whether the recommendations were actually implemented. For the interest of time, I'm going to go over 3 other studies quickly. Now, you can pause the slide and read more about the study, and also I provided a link to an article I just published that has the same information about actually all the studies that I just presented. So the next one we'll go over quickly is APOL1 bi and monoallelic variants and chronic kidney disease in West Africans. And in this study that was done in Ghana and Nigeria, this West African population that had 1 or 2 APOL1 risk alleles had a higher odds of chronic kidney disease and focal segmental glomerulosclerosis. Next study, semaglutide in patients with overweight or obesity and chronic kidney disease, but without diabetes. Okay, so here semaglutide, also known as Ozempic, reduced albuminuria in overweight or obese patients with CKD, even without diabetes. So many times I'm asked, patients with chronic kidney disease, can I take semaglutide? Is it going to hurt my kidneys? My answer is no. If anything, it may help your kidneys, and this is the proof. That was published in the New England Journal of Medicine. Now, this is down to eGFR 25. Below 25, patients were excluded. The follow-up was short, 24 weeks, and the number of patients was only 100, but the results are very reassuring. Last and not least, this study that investigated giving sodium zirconium cyclosilicate, also known as Lokelma, on non-dialysis days, plus dialyzing on 3O potassium bath for patients with hyperkalemia versus dialysis on 2O potassium bath and no binder, no potassium binder, and they studied the effect on hyperkalemia and cardiac arrhythmia. So which is better, to dialyze the patient on a 2O bath or to do a 3O bath and give Lokelma on non-dialysis days? So the answer was, in those hyperkalemic patients, giving sodium zirconium cyclosilicate on non-dialysis days was better. Okay, so there was significantly less cardiac arrhythmias and atrial fibrillation compared to just doing potassium on 2.0 bath and no sodium zirconium cyclosilicate. This is the end. Please like the video, share the video, subscribe to the channel. Thank you very much.